from India. I am presenting a case on bladder endometriosis, a rare entity. It's not, the slide is not continuing forward.
Yeah, no, I don't know why, but it's not.
Yeah, it's only the first slide. Yeah, now it's gone. Okay.
Yes.
No. It's not continuing. Excuse me.
Yeah, we can see your slides, just the first one.
Yeah, it's not.
It's not going.
Now it has come, but I don't know whether it will go on.
Okay, maybe try to exit and enter again, maybe.
Okay, okay. So I'll start now. Endometriosis is a chronic condition, usually gynecological, of unknown cause. It is characterized by the presence of functionally active endometrial tissue outside the uterine cavity. Its prevalence is around 10% of the women of reproductive age group. Can you see the next slide, or it's first one only?
Yes, we can see the next slide.
Okay. The common sites are the ovaries, uterine ligaments, cul-de-sac, uterovesical peritoneum, the fallopian tubes and rectosigmoid colon, and the bladder, as you can see in the picture. The endometriosis of urinary tract was first reported by Judd in 1921. Urinary tract is involved only in 1% of cases, of which 84% involve bladder. Bladder endometriosis usually mimic recurrent cystitis. It may present with variable symptoms like hematuria during menstruation. Early recognition and timely management can reduce the morbidity. I report a case of bladder endometriosis, which was coincidental per finding in a case which was taken up as fibroid uterus. A 33-year-old female, para 2L2, both vaginal deliveries, victimized, presented with chief complaints of a swelling in pelvic region for 2.5 years, heavy menstrual bleeding for 6 months, intermenstrual bleeding for 6 months, and lower abdominal pain for 6 months. On examination, vitals were stable. Per abdomen examination, normal contour of abdomen with inverted umbilicus, and on palpation, a cystic mass was felt in suprapubic region arising from pelvis, more towards right side. Globular, 4 to 5 centimeter in size, smooth surface, regular margins, which were tender and mobile. On per speculum examination, the cervix and vagina healthy. On per vaginum examination, uterus retroverted, 8-week size, firm, mobile, tender, smooth surface, and regular margins. A cystic mass 4 to 5 centimeter felt in right anterior fornix, left fornix normal. On per rectal examination, rectal mucosa mobile and no induration. On ultrasound, as you can see in the picture, that bladder is the report was like bladder is well distended, lumen is echo-free, walls are regular, and both uterovesical junctions are clear. About the uterus, it was enlarged, showing a hypoechoic lesion of 5 to 6 centimeter. That was fibroid uterus posteriorly. Left ovary normal, and right ovary showed a 5 centimeter size of cyst, which was clear. Now on MRI, again the urinary bladder was well distended and appears normal. Well encapsulated altered signal intensity, lesion in the posterior wall of uterus extending in the POD and displacing the uterus anteriorly. Likely it was a subserosal fibroid, as you can see in the picture here. And well-defined complex cystic lesion in the right adnexa and a communicating right hydrosalpinx was there. So considering it as a case of fibroid uterus with ovarian cyst, myomectomy with ovarian cystectomy was planned. Now, after opening, the para findings were like that. The omentum and abdominal muscles were adhere to whole of the pelvic mass. Uterus, bilateral tubes, and ovaries could not be visualized separately. On dissection, as you can see that here is the bladder and the hydrosalpinx, and all of these is adhered in the endometriotic tissue. After further dissection, 7 to 8 centimeter size fundal fibroid was present, which was keeping the uterus retroverted. Right-sided hydrosalpinx and an ovarian cyst was present. Now, bladder was adhered densely with anterior surface of uterus and a hard, firm to hard mass, irregular in shape of around 6 to 7 centimeter was present involving the bladder. So, urosurgeon was called. So, further dissection revealed it was a case of bladder endometriosis involving bladder mucosa partially and whole thickness of bladder wall in 6 to 7 centimeter area. So, it was resected. Now, the resection was done and it was followed by a dye test. Myomectomy and right self-injectomy done and mental biopsy was taken. As you can see in the picture, it was a fibroid was removed and sent for histopathological examination. Now, in the post-op period, 2-unit fresh fluorescent plasma and 2-unit PEG cell volume were transfused. The Foley's was kept for 14 days. Rest post-op period was uneventful. Leuprolide injection was given before discharge. On histopathological examination, urothelial line tissue with presence of endometrial glands and stroma was present, as you can see in the picture. So it was a per-op diagnosis as patient had neither the urinary symptoms, dysmenorrhea or dyspareunia that would suggest endometriosis, nor it was detected with radiological findings. There was partial involvement of bladder mucosa, so it might be a reason of absence of urinary symptoms. Now, post-op, the MRI was reviewed, which showed that here the urinary bladder wall thickening was there, which was missed in the pre-op period. Now, the theories which would suggest about the endometriotic spread, that endometriosis is characterized by the presence of ectopic endometrial tissue outside the uterus. Various theories are there, the coelomic metaplasia, the embryonic theory, the migratory one, which is the most accepted one, and the, as you can see, the retrograde menstruation. That's why the PSPV examination is contraindicated during menstrual cycle. So it is a disease of reproductive age group, as endometriotic tissue requires estrogen to grow, so it generally regresses after menopause. The patient may present with dysmenorrhea, backache, pelvic pain, lower abdominal pain, irregular menstrual cycle, and infertility. Nowadays, scar endometriosis is also on increasing trend. As you can see here, that bladder endometriosis is defined as diffuser muscle invasion by endometriotic tissue. Invasion can be partial or full thickness. It usually develops in the bladder base and dome rather than in the extra-abdominal space. Urinary tract involvement accounts to only 1% of the patients of endometriosis, out of which bladder is involved in 84% of cases. These patients usually non-specific and may present with frequency, urgency, pain in suprapubic area, dyspareunia, dysuria, and hematuria. Cyclical hematuria is present only in 20 to 35% of cases. According to its origin, bladder endometriosis may be classified as primary, which is of a spontaneous origin, and secondary, that is related to an iatrogenic lesion occurring after pelvic surgery, such as cesarean section or hysterectomy. Other pelvic sites are involved in 90% of cases, and in our case, except for bladder, omental nodule was also present. Although it can be detected on transabdominal ultrasound, but transvaginal ultrasound gives a better picture and of extension towards uterus and vesicovaginal septum. MRI is much better for identification of lesion and bladder wall infiltration, and usually it is seen as a filling defect or bladder wall thickening. Now, the cystourethriscopy is a magical tool for its diagnosis. It is visible as dark blue solid lesion or a growth, or like with an edematous halo with bulla or cyst, as you can see in the picture, it's visible like a growth. The definitive diagnosis is obviously by histopathology, which shows the presence of chronic inflammatory infiltrate, columnar to cuboidal cells along with endometrial cells. The aim of treatment is to give patient a healthy life, and it can be achieved by expectant, medical, or surgical methods. For asymptomatic patients, conservative approach is a better option. Pain can be relieved by continuous progesterone-based regimes as pills, intrauterine devices, injectables, and implants. Combined estrogen and progesterone therapy that can be continuous or sequential, as the OCPs are the cheapest one. GnRH analogs as leuprolide injections with or without ADPAC therapy. The surgical modalities are transurethral resection, partial cystectomy, either open or laparoscopically. The treatment of choice is endoscopic resection of the lesion. To conclude, I would like to say that as endometriosis is a multi-organ and systematic inflammatory disease, so it requires multidisciplinary approach. Proper history, examination, and investigations evaluated by experts is an adequate tool for timely diagnosis and management of bladder endometriosis. These are the references. Thank you.
Many thanks.